Great. Well, good afternoon, everyone. I'm glad it's not immediately after lunch, and hopefully you've caffeinated a little bit. By way of introduction, I'm a psychiatrist. I treat adult patients about 50% of my time, and then my other half-time job is as a physician's physician. The physician health programs, in case you're not familiar with them, were developed by volunteer physicians, recognizing that a lot of physicians were hurting with various ailments and going underground with their health problems because they feared discipline or feared that their reputation would be in jeopardy. And with the advent of these programs, which really began in the 1970s, we see more physicians coming in earlier before impairment is reached to get their health problems taken care of. And so today what I wanted to do is talk a little bit about some of the things we see at the physician health programs. No conflicts, at least no financial conflicts. So I'll talk a little bit about what I call occupational hazards, and this is different than the needle stick or being exposed to tuberculosis with an actively sick patient. And I want to talk a little bit about chronic stress and why that's bad if we don't do things to mitigate the amount of stress we experience every day. And introduce to you a work and wellness toolkit that was developed in Colorado and is free to all physicians around the world. So here are the 8 occupational hazards facing physicians, and I shouldn't say just physicians, medical students, residents, and in addition to practicing physicians. And I'll go through all of these very briefly. Typically, this is more like an hour-long talk, so I might fly through the slides, but you're welcome to have a copy of these slides. So the first occupational hazard is a high degree of work stress, and there's really no way to get around it. I mean, we are in a stressful profession for a lot of different reasons. And we all came into this knowing that sometimes we'd work long hours, that we would be lifelong learners. And for many of us, that's the appeal of going into medicine, that we're always learning something new, that we'd have a lot of responsibility when you think of it. We are responsible for other people's lives. And that at times we'd make sacrifices, for example, having to work on a holiday or missing a child's birthday party because of an emergency. But there are other kinds of stress in our profession today. For example, unhealthy workplace competition. I see sometimes, I hear all of this at the PHP, these battling groups in town, 2 anesthesia groups vying for the same, contract with a hospital and getting downright nasty with each other. Fewer jobs for graduates, which is, a newer thing in the last few years. Typically, if you got through medical school, you were guaranteed a residency and pretty much guaranteed a successful career, and now sometimes that's not always the case. And I'm just not going to go through all of these here, but even things like diminished compensation, physicians still are rewarded well for the work we do, but especially in more for-profit corporate medicine, there's always a push to treat the sicker more quickly for less money. And then sometimes we face stigma. For me as a psychiatrist, we are kind of a marginalized subspecialty, and our patients are also kind of stigmatized, but we're tough enough to deal with it. Other stressors, every day we experience at least vicariously upsetting experiences. I can remember my first rotation as a third-year medical student was on a surgery rotation, and this young girl, she must have been 6 or 7 years old, brought into the emergency room and had been attacked by a pit bull, and her face was just mauled. I mean, deep, full-thickness lacerations, screaming at the top of her head. And, really what we needed to do after we helped this patient was to debrief, but none of that ever happened. It's just kind of like you go on to the next patient. Mistakes are very upsetting. We will make them, and it's really what you do with the mistakes, not the fact that you make one. And in medicine, we are moving from more of a system of retribution, shame, blame, punishment, to a just culture. I don't know how many of you are familiar with that concept, but it's about looking at the system, not just the individual, but where was the system not catching the error. We sometimes work in a more adversarial world in medicine today. Patient complaints, threats of lawsuits. Regulatory agencies are working long and hard, and with this opiate epidemic, I can tell you they're under pressure to reduce the number of accidental overdoses, and so the way sometimes that happens is to be more punitive with doctors. What's interesting about this epidemic is, you know, for those who've been practicing for a while, there was a time in medicine we were criticized for undertreating pain. And the idea was to give those narcotics out liberally, right? And now we're having to rapidly change the practice of medicine. The patients aren't happy, and we're not happy because this didn't happen overnight, and it's not going to be resolved overnight. I'm thinking of this recent election, like everybody is, and thinking, you know, I'm so ill prepared to be an advocate in some ways, at least in terms of Washington. But I think younger generations really need to think about that it's not just the clinical practice of medicine, but you have to be more business savvy, more politically savvy. And then I talk about acronym fatigue in medicine, the maintenance of certification, electronic medical records, PIPs, MACRA, that we just have so much change. You know, what used to take 10 years to change happens in about 2 years. So we're sufficiently challenged with new things to learn all the time. And then finally, you know, we're giving to a lot of people, not just our patients, but we have to take care of our staff, the people that support our practice. And sometimes our own needs are ignored unless we learn to incorporate self-care into our lives. And a lot of times our needs are ignored until something bad happens. We're burned out, we're drinking too much, we're depressed. What's interesting is medicine has not always been the most stressful profession, and that's because we had a lot of autonomy. And some of you in the room have been practicing long enough to remember when you could pick up the phone and order some test and it just got done. Now we pick up the phone and we talk to someone in a cubicle across the country that asks us a lot of stupid questions. They really don't even know what we do, but we have to go through that every day. You can think of the stress we experience in the workplace as a ratio of something called mental workload versus decision latitude. And it's similar in the business model where you talk about having a lot of responsibility but little authority. This model kind of fits. And you can think of mental workload just as the amount of responsibility, how challenging the decision making is, and the decision latitude is just how much autonomy do we have to implement what we want to do. So you can imagine with a high level of mental workload and low decision latitude, that's going to be very stressful. And the way you can think of that is the medical student who has high mental workload, steep learning curve, right? Very little authority or autonomy. That's stressful. The resident has a little more medical knowledge, so not quite as steep of a learning curve. So high mental workload, but not as high as a medical student. A little more decision latitude. They have a little more responsibility. And the attending has all kinds of other stressors, but it's not so much in the medical care because they are seasoned and they have much more authority than anyone else on the team. Depression is the second occupational hazard. And it's interesting that physicians are not very good at recognizing depression in themselves or ourselves. And my own opinion about that is we are so other-directed and so responsible and conscientious about getting the work done that we're not taking our own pulse every day. It's about the same in practicing physicians as the general population, but we tend to have a later onset of the first episode of major depression. For example, most people who develop this condition develop the first episode in late teens, early 20s. For physicians, it's more like late 20s, early 30s. And it may have something to do with us being pretty darn resilient until there's a straw that breaks the camel's back. And there's also, unfortunately, a lot of people who stay underground. They don't report it. One, they don't recognize it, or two, they know it. But there's a lot of fear about it becoming public because of stigma and other reasons. So here are some of the signs of depression you might see in the workplace. You know, someone being withdrawn, less friendly, losing their humor, preoccupied, change in their physical appearance. And a lot of times we see that, or we feel it ourselves, and you think, I'm just stressed, or, Mary Jo is just stressed today. And unfortunately, that delays the diagnosis of depression, and that can have very severe consequences. And one of them is suicide. This is the third occupational hazard we see in the House of Medicine. And physicians complete suicide 2 to 4 times more than the general population. Particularly women physicians, it's 130% higher than women in the general population and 40% higher for male physicians. And, I've had some reporters call me because this has been in the news a lot more. We're beginning to look at this dirty little secret in the House of Medicine. And they cannot believe that number, 400 physicians a year. And I say yes. And their thought is that this is a new phenomenon. And sadly, this has been the same for decades, this rate of suicide. And even more frightening is it's probably a conservative number because many suicides don't get reported. They're reported as accidental deaths, accidental drowning, motor vehicle accidents, and so on. These are risk factors that you see in the general population, some that we've really captured and that we use to try to assess risk and prevent suicide. And many physicians have similar risk factors. At the Colorado Physician Health Program, we did some research. We mined our database of about 30 years, and we looked at attempted suicides, and we're able to look at the risk factors, and we had the benefit of being able to talk to the physician because they survived their attempt. And what we found, which is very important, is that even absent a mental illness diagnosis, if a physician is contending with multiple and severe stressors, that is an independent risk factor for sudden, unforeseen suicide. For example, having a bankruptcy, going through a lawsuit, and maybe having a sick child altogether. Those kind of stressors can be overwhelming and paralyze an individual that in the moment thinks there's no escape from this, there's no way I can solve this problem, and they go on to precipitously commit suicide. We know some other unique risk factors for physicians are that we have knowledge about lethal means, right? Injecting potassium chloride, for example, or an overdose with something like fentanyl, a potent synthetic opiate. And so we know how to successfully commit suicide, and we also have access to those means in our workplaces, at least most of us who are hospital-based or in surgical centers. Another issue I think that interferes with physicians coming forward with a depression is that we identify ourselves as healers, right? We're there to help other people, and we can be extremely uncomfortable in the patient role. And also, this illness is still very stigmatized, and we may feel shame about being ill. All of us were trained in an environment where you should be tough and resilient and you're the cream of the crop, and so to acknowledge any kind of vulnerability can be hard. So addiction is the next occupational hazard. This photograph depicts an anesthesiologist injecting fentanyl into his saphenous vein. And this is obviously not I didn't capture someone in the act, but the addiction among physicians is very similar to the general population. Alcohol tends to be our drug of choice, I think, because it's legal mostly. People aren't going to get in trouble with their medical boards for drinking unless they get a DUI. With marijuana becoming legalized, we may see that becoming a popular choice chemical for physicians as well, but haven't really seen that yet. It's important to remember that addiction is a primary chronic neurobiological disease. It also has genetic, social, and environmental factors. And the first drink, anyone in recovery or that knows someone in recovery, they'll say the first drink is a choice. But if you have the genetic loading for addiction, it soon does not become a choice. It's very compulsive. You have impaired control over use, and it's continued use despite harm and craving for that drug all the time. And this is all because the brain rewires so that it is hijacked by the addiction, and the addiction becomes more important than childcare, practicing medicine, making money, any of those things. We always talk about chemical addictions, but I'd like to remind you that work can be an addiction and have some of the same negative consequences. Disrupting sleep, interfering with relationships, becoming irritable, being fatigued, having somatic symptoms that you might have with an alcohol disorder. The good news, and it's this very research that's happened in the last decade or so by physician health programs, is that physicians have a phenomenal recovery rate. If you look in the general population, the recovery for addiction is about 30 to 40%, and that's considered pretty good. Physicians have a recovery rate of over 90%, and you'll see that at about the 5th year mark, let's see if I can, well, you guys can't see that, right? At about the 5th year mark, you see very few relapses. So what we do, the formula for good addiction treatment, is intensive residential treatment to start, because physicians won't stop working. That's why we send them off to a residential facility. They will bring their cell phones, they'll try to prescribe over the phone, stay in touch with their patients. So we really need to disconnect them from work. Then there's aftercare, which involves 12-step meetings, urine drug screening so that they can go back to work and the public is safe. And then monitoring. At the PHPs, it's supportive monitoring. It's education about wellness. It's education about stress management, time management. So by the 5th year, they're good to go. And historically, medical boards would basically revoke licensure or suspend licensure when a physician had a severe alcohol problem. And now they agree with this type of recovery model. And generally, physicians are on a contract with the medical board or stipulated agreement for about 5 years, because that's when we know we have the best success. Burnout, just like physician suicide, burnout is in the news. I can't think of how many articles I've read about burnout, and they're all good. And this morning we were having a conversation that, you know, all of these organizations are siloed off and doing good things, and we really need to cross-pollinate and collaborate and not reinvent the wheel, but go to the next step, which is not just saying, yeah, burnout's a huge problem in medicine, but what do we do about it? And just remember, this is a syndrome with a triad of symptoms, the first being depersonalization. And basically what that means is you're just detached. And it really is kind of an emotional protective mechanism, that you're not going to get too close to your patients, you distance from everybody around you, because you're in so much pain, you're kind of shut down. Emotional exhaustion, and that exhaustion isn't remedied even with restorative rest. Say you have a long weekend, you sleep 10 hours each night, you're still emotionally exhausted the Monday you return to work. And a diminished sense of personal accomplishment. And that's probably the most painful. And if it's unrecognized burnout, physicians retire early or get another career, not recognizing that they actually suffer from something that can be treated. And that diminished sense of personal accomplishment usually is in the form of thinking your work has no meaning, that you're not making a difference, or that you're just not very efficacious at what you do. And this is kind of what burnout looks like. At the beginning of this slide, you can see that performance is improving, right? This is someone that's getting up to the challenge. And in the next section, this is really the sweet spot. The challenge is just right to have superior performance. And that's where we want to be, and that's where we can be if we take care of ourselves. Right here, the individual's stretched. And what I mean by that is the challenge is becoming greater than the optimal performance that physician can provide. And it's not that the physician's losing his or her skill, it's because the challenge is unrealistic. And that challenge may be high patient volume, administrative burden, personal problems that distract you from your work. It can be any of those things. And in this stage, which is really pre-burnout, you're going to see insomnia, irritability, bruxism. My dentist says all her doctor patients have mouth guards at night, including this one. So you're just, you may be using caffeine in the morning to get going and a little Ambien at night to go to sleep, but you're not well at that point. That's when you can intervene before getting in trouble. And then this final stage is really where you cannot keep up with the challenge and you crash. And this is where we might see impairment, actually, meaning you're unable to practice medicine with reasonable skill and safety. Burnout and error, there have been studies done. This was done by one of my colleagues, Mick Oreskovich, who was a surgeon, burned out and drank too much, and switched and became a psychiatrist. But he's still very involved with his surgery friends and colleagues. Conducted a survey and among a high number of surgeons, and just asked them if they thought they ever made errors because they were sleep deprived or burned out or depressed, and many of them acknowledged that that was the truth. And what we also know is that burnout can be as impairing as a high blood alcohol level, and we really focus on addiction in medicine, almost to the exclusion of some other things that can be quite impairing that we need to look at. How many of you have a personal physician? It's about a third, and that's usually what I see. Physicians are notoriously bad about having their own primary care doctor, and that can make our health not be so good. And when you think about it, we have these circadian rhythm disruptions, right? Sleep deprivation, never know when you're going to sleep, or you sleep at odd times. Sustained stress, which is what I've talked about, and the vicarious trauma. And our training sets us up not to take care of ourselves because we adapt to these extreme conditions of sleep deprivation, not eating, not seeing the light of day for up to 36 hours, right? That we're focusing on other people, and again, historically, very little education about stress management. That's happening now in the medical schools, but it hasn't always been there. So, just a reminder that sustained stress is not benign. Our sympathetic nervous systems were designed for spikes of high energy to outrun the bus that's about to hit you on the street, right? We're not supposed to have sympathetic arousal all the time. And it's really like taking an exogenous steroid because cortisol levels are elevated, and all of you know some of the bad effects of steroids listed there. And with high cortisol levels, we also develop atrophy in our hippocampus. And if you remember the hippocampus, that's for new learning and memory. So stress can actually impact the bottom line. You know, we are cognitive creatures in practicing medicine. And then in the interest of time, I'm going to push through these, but all these neurotransmitters get depleted when you're stressed, and they involve regulating mood, sleep, pain management, the ability to experience pleasure. We sometimes get poor health care because we, like I said, don't get personal physicians, and we engage in a curbside type of medical care. You know, what antibiotic would you take for this, and then self-prescribe for that antibiotic. We might even have poor health care for our families. Now, sometimes physicians don't want to know their spouse has an alcohol use disorder, and so they try to detox that spouse at home. Or maybe with a child, you either overdiagnose because too much knowledge is a bad thing, or you underdiagnose because you minimize because you're fearful that your child has a bad illness. But the important line is that we are not objective about our own health, we're not objective about our family's health, and that we should never self-treat. Just briefly, some barriers to treatment. There's a lot of concern about discrimination. How will people look at me if they know I have this disability or I've had this condition before? Will hospital credentialing bodies discriminate against me? Will my medical board punish me for being ill? Colorado has a really nice model. We call it a safe haven with our physician health program, that any physician that comes to us with any kind of illness, no matter how severe, as long as they come to us, they get the care they need, they never have to disclose it to the medical board. And that's very different than other states. And what we've found is we get a lot more self-referrals earlier in the course of illness versus complaint-driven referrals when someone gets reported to the board after they're impaired and after there's been patient harm. Unhealthy relationships, interpersonal relationships, I'll just say that historically medical marriages were pretty bad, high divorce rates, higher than the general public. But with younger generations coming in, Gen X, Gen Y, millennials, there is more of a demand for work-life balance. I think it's a good entitlement to have. And so you see healthier marriages. So be happy about that. I will say, don't act like a doctor when you're at home. I say that to lawyers too. Don't be a lawyer when you're home, because our personality styles in the workplace can be one of being very obsessive compulsive and kind of directive, and we can develop a little bit of a me, deity posture, and that's disastrous in relationships at home. So take your doctor hat off when you walk into your home. And just here, I'm just saying that, if you have supportive relationships outside of the workplace, it tends to make your work or professional life more positive. And if you don't, you tend to be more professionally disillusioned as well. This one is really much more for a male audience about boundary violations, at least sexual boundary violations, but it can happen. And if you're stressed and you're not taking care of yourself and you're going through a divorce and you're drinking too much, and you have a seductive patient that says, "Doctor, you're not looking so good," and they bring you in gifts, and that table can turn where all of a sudden this patient is nurturing you, and it can go to a very bad place. So this is probably a lecture all by itself, but just be very mindful of maintaining good professional boundaries. So we need to have a cultural shift about the hazards being in the medical profession. And take this, you can have all these slides, but this is one I'd like you to pin onto your refrigerator. It just says stress reduction means altering work, altering attitude, and engaging in self-care. In 2011, the Colorado Medical Society did an all-member survey and found out that morale was very low in Colorado among physicians. And about half of physicians said they could, have some type of healthy lifestyle. The others said no. And we know that there are many studies that correlate physician wellness with patient safety. And we were really concerned, if our physicians are suffering this way, what is it doing to the patient safety in the state of Colorado? So through a collaboration with different entities in Colorado, we developed Dimensions, which is a toolkit for physicians. And it basically is all evidence-based ideas. It's very flexible in that if you only have 5 minutes, you can spend 5 minutes somewhere in that book working on a new skill or solving a problem, or a whole weekend. And it's at this website. I would encourage you to download that. It really is a pretty good toolkit for self-care. And finally, I'll just stop with this slide, that the reason we want to take care of ourselves, because if we're healthy, we deliver better patient care, and that's been demonstrated through research efforts of Erica Frank. I don't know if you're familiar with her work, but she's really shown that over and over again. Thank you for your time.